Hello, everybody, and welcome. I hope you've had a great DDW. It's been a busy few days and it's all virtual. So we're grateful that you've chosen to spend a little time with us tonight. I'm David Rubin. I'm from the University of Chicago. And on behalf of CME Outfitters, I want to thank you for joining us for today's virtual symposium titled Opening the Window of Opportunity: Strategies for Successful Treatment and Management of Patients with Crohn's Disease. This activity is supported by an unrestricted educational grant from Janssen Biotech, which is administered by Janssen Scientific Affairs. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians like you worldwide. Today's CME and CE activity is also eligible for ABIM mock points. So make sure you engage in today's event, answer the polling questions, submit questions to us, and provide your feedback, which is really important for future programs. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your mock points for you. You can also claim this activity as CME for MIPS improvement activities. We are also streaming this webcast over social media platforms. I'm sure you're not surprised to hear that. I would like to encourage everyone to join us today on our live Twitter conversation. We will be monitoring the Twitter feed and responding to your tweets as they come in. We really will. Finally, we are using an enhanced platform today that allows you to save slides, take notes on your slides, answer polling questions, and send us your questions, which I will be moderating. We'll be taking your questions throughout the program, so don't wait until the end to send me something. I'm going to be keeping an eye on it, and I will be engaging my faculty colleagues, Dr. Afzali and Dr. Long, and we'll be addressing your questions throughout the program. As I mentioned, I'm David Rubin, and I'm from the University of Chicago, and I'm joined today by two outstanding faculty members. We're going to really make it worth your while tonight. It's Dr. Anita Afzali, who's an associate professor of medicine in the Abercrombie and Fitch Endowed Chair in Inflammatory Bowel Disease and the director of the IBD Center at The Ohio State University. She also directs their Advanced IBD Fellowship Program. We're delighted to have her expertise with us. And also joining me is Dr. Millie Long, who is an associate professor of medicine and director of the Gastroenterology and Hepatology Fellowship Program, as well as vice chief for education in the Division of Gastroenterology and Hepatology at the University of North Carolina at Chapel Hill. So welcome, Anita. Welcome, Millie. Delighted to have you both with me for this final program of a busy DDW. Millie, why don't you kick us off today with our first learning objective?
Absolutely. Thank you, everyone, for joining us. Today, we'll be talking about Crohn's disease and specifically trying to differentiate biologic therapies based on their mechanisms of action. We'll focus on the efficacy, safety, and the ability to induce both a rapid and durable treatment response to help to inform you how to make some of these decisions. So we'll start with a case. I always frame everything around a case because a patient is what drives all of my research questions and obviously what drives me to improve their outcomes. And so Caitlin is a 24-year-old woman, and she has intermittent, pretty significant right-sided abdominal pain, and it's come about in episodes over the past year. She's also had a mild increased frequency of bowel movements up to 5 times daily, but has not had any blood. But she has lost a significant amount of weight, about 20 pounds. And intermittently, she'll have a feeling of her belly getting more distended and pain after eating. And that seems to have gotten worse in the past several weeks. She does have iron deficiency anemia, and her albumin is 3.3, so a little bit low, but not terrible. And she had been seen recently at an urgent care, and she had a CT done that showed a short segment stricture in the distal terminal ileum with pre-stenotic dilatation. And so obviously, as we were working her up, one of the things I wanted to do was perform a colonoscopy. Her colon is totally normal, but she actually does have this stricture, as you can see on the right side, in her ileum. That's really quite pinpoint. I could not get past it. But as is the case in many of these times, I took some biopsies kind of just through the stricture, and she has severely active chronic ileitis. And as you're talking to her, she tells you she's interested in a pregnancy in the next few years and that she travels for work. So those are some things we want to consider as we're thinking about how to treat Caitlin. So next slide. At this point, I'd love to have you all be involved and tell us what you would recommend for Caitlin. And obviously, I understand there could be a combination of these things, but what would you do next? She could have surgery. She could get initiated on infliximab. She could get initiated on combination therapy with adalimumab and azathioprine, ustekinumab, vedolizumab, or you're not sure. There are a lot of options. So please do key in your response. So we're going to come back to Caitlin and what you thought you'd do at the end of this presentation. So in the next 20 minutes, we'll talk about treatment targets in Crohn's disease, that there really is a window of opportunity. That there are many therapies for moderate to severe Crohn's disease that we'll discuss. What do the guidelines tell us? Talk a little bit about positioning and how we have to extrapolate data. From a safety perspective, I'd just like to focus on pregnancy, since that's one thing that Caitlin was concerned about. And then we'll end with some unmet needs for Crohn's disease that we hope we'll be able to address in the next several years. So this window of opportunity exists potentially earlier in diagnosis, where an individual at diagnosis starts to have inflammatory disease, and that can then progress to stricturing disease that ultimately may require a surgery. But that window early on may be a time where much of this is actually reversible. I would argue that potentially Caitlin, our case, is actually much further down this road than it would be if it were earlier and able to potentially reverse. Next slide. So one of the things that is really important is that in Crohn's disease, symptoms don't always correlate with inflammation. So I think for a long time, many of us have used symptoms to diagnose, to monitor, to follow patients with Crohn's disease. But this is just a nice plot that demonstrates the association between symptoms and endoscopy with the Crohn's disease activity index on the y-axis and the severity of ulcerations on the x-axis. And as you can see, there's no association here. There's no direct line, meaning that someone can have quite severe inflammation and not be symptomatic, or potentially the reverse could be true as well. So we need to use different targets. Next slide. So these are the recent STRIDE-2 treatment targets in Crohn's disease, where an individual who has active disease, you select a therapy for that person according to their risk. You look for a symptomatic response, but you're also using other targets, both short-term, intermediate, and long-term. And in all of these instances, we're starting to use biologic targets, meaning things like biomarkers, CRP, a fecal calprotectin, but most importantly, endoscopic healing, which is what I use in my practice. There are some adjunct targets, things such as transmural healing on radiology or histological healing, but we're not quite there yet, but that is truly a goal. It's really the idea of improving someone's clinical symptoms, biomarkers, and making sure that the bowel is healed. Next slide. So currently, as you all very well know, we have 3 biologic classes available for the treatment of Crohn's disease. Within the anti-TNF class, we have 3 options: infliximab, adalimumab, or sotolimonab pegol. Within the anti-integrin class, we really have vedolizumab. There's also natalizumab, but I'm not going to emphasize that during this discussion because vedolizumab is a much safer option and what we're using predominantly in our practice. And then we have an IL-12/23 inhibitor, ustekinumab. Next slide. So where can we go with guidelines? So guidelines for induction therapy in moderate to severe disease, certainly one can use oral steroids, which can be very effective in the short term. It's just not something you want to continue, and you always need to have an exit strategy for maintenance. Anti-TNF agents in steroid-resistant or thiopurine or methotrexate refractory disease per our guidelines, and that our guidelines tell us that combination therapy with infliximab is more effective than monotherapy with either thiopurines or infliximab alone, particularly for naive patients. Anti-integrin therapy is an option. Ustekinumab therapy is an option, both with or without immunomodulators. And you'll note that these guidelines don't tell us anything about positioning because until this weekend, we have not had head-to-head data for one biologic as compared to another. Next slide. So maintenance therapy, the immunomodulators are still an option for maintenance therapy after a remission has been induced with corticosteroids. But if someone is steroid dependent, you should not be continuing on that immunomodulator alone. That's where other medications certainly can be considered at that time. For anti-TNFs, you really want to use an anti-TNF to maintain that remission. And again, remember the role that combination therapy may play. And vedolizumab or ustekinumab can both be used to maintain a remission induced by each of those agents. What do we know about sequencing or positioning? Until now, with the CView trial that we'll touch on, that was presented here at DDW, there have been no head-to-head randomized controlled trials to demonstrate comparative efficacy in Crohn's disease. So we really have to rely on other forms of data to help us with positioning. Things like subgroup analyses from randomized controlled trials, real-world evidence, cohort studies, and network meta-analysis, which really provides indirect evidence. So from that data, after failure of a first anti-TNF, second-line biologics really do appear to be less effective, including second-line TNFs, and that comes from subgroup analysis. We know that ustekinumab is still effective after failing an anti-TNF. Ustekinumab is also effective after failing vedolizumab, and that TNF inhibitors do seem to be effective after failing vedolizumab. But that in real-world data, vedolizumab may be less effective after failing a TNF in Crohn's disease and may actually have a longer onset of effect after TNF failure. So these are nuances that can help us to understand, but really what we need is head-to-head data comparing one mechanism to another. And so that brings me to the CView trial, which was presented here at DDW as a late-breaking abstract. This was a multi-center, randomized, blinded, active controlled study. So essentially individuals were randomized to either ustekinumab or adalimumab for Crohn's disease. And it was a treat straight through design where they were treated for the course of a year. And at 52 weeks, they had a primary endpoint, which consisted of clinical remission, steroid-free remission, and then also endoscopic healing. And so this study, while there was not dose titration of either agent, really provided us a look at standard therapy with each of these agents and what the outcomes are. Next slide. And so the CView primary results for the primary endpoint of clinical remission, which was a Crohn's disease activity index of less than 150 at week 52, you can see that for adalimumab, the rate was 61%. For ustekinumab, it was about 65%, and there was no significance amongst those differences. And then when you look at corticosteroid-free remission, you're also seeing very similar rates with adalimumab at 57.4% and ustekinumab at 60.7%, again, not statistically significant. And when you look at this, this is actually quite good. These rates of clinical remission and steroid-free clinical remission of the neighborhood of 60% are exceptional. That the fact that we can get that many people into clinical remission with these drugs. But it doesn't really tell us one is better than the other. It tells us that each of these drugs is effective. And one thing that was interesting about this study design is that these were individuals who hadn't necessarily previously been on other agents. They could have been on, obviously a corticosteroid course, immunomodulator, but they had not been on these biologics. And so they were potentially a little bit earlier in their disease course, and we can see great effects there. So I think this study can tell us a lot. What does it tell us about positioning? Well, I think we need to think about the individual characteristics of each patient as to which of these therapies may be best, because in this study, they really look to be quite similar. Next slide. So how do we put together the puzzle of therapy selection? You really have to think about a number of factors associated with the drug. For example, the indication, how rapid the onset is, the pharmacokinetics, the safety and the specific concerns for your individual patient, and those characteristics of the patients themselves. How old are they? Do they have comorbidities? What are their patient preferences? We started this discussion with Caitlin, who really knows she travels for work and infusion is going to be tough. We want to set our patients up for success. The disease characteristics, whether that be Crohn's or ulcerative colitis, their phenotype, early versus late in their course, whether they have extraintestinal manifestations. We have to use all of these factors to help us with positioning. So TNF inhibitors, there are a number of pros to TNF inhibitors. I think that one of the things I really like about them is the very rapid onset of action. They're an agent that has proven randomized controlled trial level data in fistulizing Crohn's disease. Because of their rapid onset, they work effectively in hospitalized IBD. And really a variety of extraintestinal manifestations. We've seen pregnancy data that is safe, therapeutic drug monitoring is well accepted. really a robust data in postoperative setting for Crohn's disease. However, there can be some cons as well, whether that be infection risk, some of the paradoxical reactions, the contraindication. But I'd like to focus just on one pro and one con as they relate to Caitlin. So we'll start with robust data in the postoperative setting. You know, one of the things I'm considering for Caitlin is surgery. And so what would I use postoperatively to help to control her disease? Next slide. So the PREVENT trial looked at the impact of infliximab on clinical and endoscopic recurrence. And as you can see here in the left panel, on subjects with clinical recurrence prior to at week 76, this P was not significant, although obviously for infliximab numerically lower. So when you look on the right panel at endoscopic recurrence, which is potentially what occurs prior to the development of clinical symptoms, you can see that the infliximab group, which is the yellow, had a much lower rate of endoscopic recurrence based on the Ruckert score. So this is really our highest level of data for preventing recurrence after resection. Next slide.
Hey, Millie, could I ask you a question?
Sure, absolutely.
You showed us that endoscopic photo, and she had a pretty tight stricture. Can you just comment on whether you would use cross-sectional imaging, or when you mentioned that you're thinking about surgery as an option for her? I know there's other things you're also going to talk about, but how do you make that decision? Does it matter if there's proximal dilation? There's an abstract at DDW this year that suggested intensive therapy might heal that, which was a surprise to me, actually.
I know that abstract bothered me a little bit because, you know, in my clinical practice, I have really found that when someone has pre-stenotic dilatation, I really don't get great outcomes out of medical therapy, and I'm almost just kicking the can down the road, and that ultimately they actually do better with a surgical resection up front, followed by medical therapy. So I do really use that cross-sectional imaging. And for Caitlin, in this case, she actually had a relatively short segment stricture, but she did have that pre-stenotic dilatation. And I think you saw that endoscopic photo, David. That is tight. And I am really worried that if I load her with a drug right now, I mean, I may be able to get us a little bit of time, but that ultimately, look at those data from PREVENT. We have great postoperative data. She's naive to other therapies, and this is a short segment. So I'd really be thinking about surgery for her. Although in a shared decision-making fashion, which we're going to hear from Dr. Afzali about later on, I wouldn't be adverse to trying medical treatment with the idea that should she not have a robust response, should she not meet outcomes that we agree on, that we would then go to surgery.
Yeah, I think that that's the key, is making sure that you and the patient are on the same page with the goal of management. Because so often patients, once they hear their diagnosis, they go to the internet and they're reading about living with active disease, essentially. You know, if you have Crohn's disease, here's what you should expect. You're not going to be well, or you have to have a job that's near a bathroom, or you won't know when you're going to flare. And I spend a lot of time dispelling those myths and trying to educate regarding our goals and how we want to make sure that they truly achieve them. Otherwise, we do need to take other steps. I just wanted to pause for that because I think
I
as
agree.
we talk about
David,
this, I thought about her.
I totally agree. And the other thing that the myth, you mentioned the myth you want to dispel. One of the myths I like to dispel is that some patients come to me and they say, oh, I should never have surgery because once I start having surgery, I'm going to keep having surgery. So I want to do everything I can to avoid surgery. The exact opposite is true. Surgery can be a tool to help to induce a surgical remission that can then, patients can do incredibly well with medical therapy. And so I think don't use surgery as a last resort, I guess is one take-home point and one myth to dispel.
And we'll come back to that when I give my presentation in a few minutes. But
Perfect.
Thank you I'm sorry to have interrupted, but
no, not at all. Not at all. It's much better to have a conversation. So as people are tweeting in those questions, let's keep talking.
Good.
So one other study that I just wanted to emphasize as we're talking about TNFs is that I learned a lot from is the PANTS study. And this is personalized anti-TNF therapy in Crohn's disease that, you know, there are very high rates of immunogenicity, both with infliximab and with adalimumab. And I think we need to keep that in mind. This was a prospective cohort that demonstrated this, that anti-drug antibodies are exceptionally common on monotherapy. And so I really, in my practice, do use a great deal of combination therapy up front to help to maximize the therapy with the idea of potentially trying to minimize it down the road. Next slide. And what's really been interesting is that there seems to be a genetic marker, this HLA-DQA105, that when a patient has this marker, they are much, much more likely to have immunogenicity. And so hopefully at some point in the future, we'll be able to use this marker to help to personalize our treatment, whether at the time of initiating therapy and choosing a therapy if you want to avoid an immunomodulator, or at a time of minimizing, going from combo to monotherapy, helping to understand who will be most successful with that. And so I think keep this in mind as a tool for the future.
Next slide. In the session this afternoon, we saw that patients who developed anti-drug antibodies to the first anti-TNF were at higher risk for developing them with their second one, which is not new. That was seen before, but there was a very nice study by Adam Chaffetz and his group looking at that. And interestingly, does not seem to be the same if you have anti-drug antibodies to an anti-TNF when you go to ustekinumab or vedolizumab, which have low immunogenicity. So lots of interesting information coming. I'm going to ask you, because I sort of know the answer, you've already started using the HLA-DQ105 a bit, haven't you? When are you using it, and how are you getting it? What are you doing?
So our lab, we have, because it's a subset of a celiac disease genetic test, our lab has been able to subset this for us. And so we are using it to work up diarrhea, as one can do for celiac disease testing. And we, through this marker, have been able to determine, for example, the way I use it the most in my practice is if I have people on combination therapy, I get them into endoscopic remission, and I want to potentially stop the immunomodulator. And so checking this level can help me to understand how likely they are to develop immunogenicity with dropping that therapy. Another way I have used it is in terms of therapy selection. If someone has a true contraindication to an immunomodulator, if they are HLA-DQ105 positive, then maybe I'd actually go with one of the alternate biologics like we're about to talk about, vedolizumab or ustekinumab, where you don't necessarily need to use a combination immunomodulator and there is less immunogenicity. So I think it could help us a great deal with a couple of different aspects of personalization of therapy. And so hopefully we'll have more data as soon as we and others are starting to use this assay.
So you're going to tell us too whether HLA-DQA105 predicts higher titers to the COVID vaccine.
We are indeed. So there are some data that this genetic marker can be associated with your response to vaccinations as well. So we're partnering with the group at Cedars in a large study that we're doing looking at COVID vaccine response and trying to understand if this genetic marker plays a role there as well. So stay tuned. Hopefully there may be a lot of implications for this.
I'll let you plug your study when we get done here.
Okay, perfect. Because I would love to have everyone recruit for that study. It's internet-based. It's very easy to recruit for. So let me touch briefly on vedolizumab and ustekinumab, because I do want to get to Dr. Rubin and Dr. Afzali's portions of the presentation. I think we all recognize the excellent safety benefits of vedolizumab, that low immunogenicity. Those are certainly no impairment of vaccination, we don't think. Obviously, we're studying that, particular to the COVID vaccine, but thus far it looks very robust. You know, there are some cons, potentially slower onset of action, as I mentioned, and at least at this point, only available as an IV formulation. So that's one thing I'd like to discuss, because remember, our patient, Caitlin, said that she didn't want IV. So is this potentially an option in the future? So next slide. These are data that were presented, I believe, at UEGW on vedolizumab in Crohn's disease, the VISIBLE-2 study, that actually looked at patients with moderate to severe Crohn's disease. They got 2 doses of standard IV vedolizumab and then were randomized to a sub-Q maintenance versus a IV maintenance. These data are actually from the clinical remission with vedolizumab versus placebo. But essentially, what has been fantastic is that it appears that there is a sub-Q formulation that will be available in the future for vedolizumab, and that appears to be just as effective potentially as the IV. This will allow some of our patients to choose to move on to the sub-Q version to help with adherence to therapy, if they travel, all of those things. So I think in the next few years, we'll be seeing that. So Caitlin may have a hope for going on to a sub-Q version. Next slide. And so ustekinumab, again, a number of great pros, including safety, the robust durability data, that it is a sub-Q dosing after an initial IV load. I really think it's a great choice for individuals with psoriasis. It just melts away. From a con, well, this could be a pro or a con. The role of TDM is not well defined. I think that this has such low immunogenicity, you may not need TDM with ustekinumab, and thus far limited data in fistulizing Crohn's disease. So from a pro perspective, it's quite durable. So next slide, I'd like to show you what Caitlin could get out of this therapy if we did use this. In that next slide, the data from UEGW on the durability of ustekinumab for Crohn's disease through 5 years are actually quite robust. And so this was nearly 600 ustekinumab treated patients. 151 placebo-treated patients terminated the study, but among those on ustekinumab, over half of patients entering the long-term extension completed their last dosing visit at week 252. That's huge. This is a big number to have people stay in this study. And as you can see, the intention to treat was really quite robust over this time period. And the long-term follow-up really showed no new safety signals. And so this is really helpful data that if this drug works, it's going to potentially keep working. Next slide. So biologic choice in the absence of head-to-head data. Think about the factors of the individual patient. Pregnancy, really great data on biologics. If they failed an anti-TNF, older gentleman potentially who's failed infliximab, I might use ustekinumab in that scenario. Newly diagnosed, vedolizumab, a great option, great safety signals. We can think about lifestyle considerations. We can think about unfavorable pharmacokinetics. David and I were talking about this HLA-DQ-A105. Once we can start checking that, if someone's positive, then maybe you want to go with a drug that has less immunogenicity. With perianal disease, I still would be thinking along the lines of a TNF plus azathioprine. So really in a shared decision-making fashion, which you'll hear more about from Dr. Afzali, really considering all of these factors in terms of choosing the right drug for the right patient. Next slide. And so finally, just one safety slide that I'd like to give a plug for the piano data, which were recently published this year by Dr. Uma Mahadevan from UCSF. And this study included 1,431 live births, and individuals were on biologics, immunomodulators, combination therapy, and essentially biologics were not associated with any adverse outcome. And in fact, it was active disease that was associated with an increased risk of spontaneous abortion and other complications. And children were followed out for up to 4 years afterwards, and there was no negative impact of drug exposure on the children. So again, from a safety perspective, as we're talking to Caitlin, if she's thinking about pregnancy, then being on any of our biologics would be an appropriate choice. Next slide. So finally, just some unmet needs. We need more direct head-to-head comparative effectiveness studies, and I know we'll probably be talking a little bit more about CView tonight. It's nice to have one out there that can help us. Personalized therapy, hopefully that is the wave of the future. And that biomarkers, we need better biomarkers that are more strongly correlated with endoscopic healing. And that certainly we need more data on combination biologic therapy in the future, postoperative recurrence beyond TNF inhibitors, and further long-term safety data on making particularly our newer agents to inform shared decision-making. So finally, just to wrap up, there's a window of opportunity that exists prior to structural damage. That targets for therapies include symptoms and endoscopy. Guidelines support the use of any of our biologic medications in the management of Crohn's disease. And that up until now, data on positioning were really extrapolated. So CView will help us in terms of a real comparative effectiveness study. And that individual patient characteristics should be considered, and that all biologics have reassuring data for use during pregnancy. So I think now, David, we are going to return to Caitlin and see what people are thinking they'd like to do for her now.
I think we're going to come back to her later.
We'll come back to that? Okay, great. Maybe after all of our presentations.
Yeah, so because there's some great questions from our audience that are already populating the panel here, and I want to encourage people to keep them coming. And some of them will be addressed in my presentation for the next few minutes. And then we'll come back to them at the end as well, because there are some very good comments here that I'd like to share with you and also with Anita. So let's move on to our second learning objective. If you can advance that, Jan, for us, which is to incorporate elements of prognosis into your treatment decisions in Crohn's based on the clinical research data and guideline recommendations. So let me also start with a case. This is a woman named Madeline who's 50 years old. She has a history of ileocolonic Crohn's disease, and she was stable on 6-mercaptopurine 50 milligrams daily, but then stopped it because she kept having sinusitis symptoms. She presents with worsening abdominal pain, diarrhea, and rectal bleeding, and you perform a colonoscopy, which shows active ileocolonic Crohn's. It's the sort of classic phenotype of the distal ileum, inflammatory but not stenotic, and proximal colon. She was treated with adalimumab and vedolizumab, but neither of them worked for her, and ustekinumab was started and her symptoms did improve. So perhaps this is a patient similar to what some of our colleagues who have joined us tonight have treated. So let's see what the audience might consider for Madeline as the next option. So remember that she did not respond to adalimumab. She did not respond to vedolizumab. She has improved symptoms with Usta, but she's coming to you now and is having some active symptoms. So what are you going to do next? Infliximab monotherapy, infliximab with azathioprine, continue the ustekinumab, consider surgery, something else, or maybe you're not sure. So how do you go about approaching this particular patient? And in fact, this gets to some of the questions that our audience has already posed to us here. So just take a minute. All right, so what you've heard now from Millie is a fabulous overview of some of the options as well as the guidelines for managing Crohn's disease. And I want to go back to what we've now established as our general approaches to inflammatory bowel disease. And I've said repeatedly and often more recently that I think we've entered the era of disease modification, meaning that our goal in managing Crohn's and colitis is to change the natural history. And the ways to do that include earlier intervention with effective therapies, treating to targets that are composite of both symptoms and objective measures of inflammation, as you heard Millie introduce. And then this other part, which I think we don't spend enough time talking about, which is tight control. And tight control is meant to reflect monitoring the disease over time. In fact, we've really moved from the acute crisis management, symptom-driven management aspect of IBD to a much more chronic care model, which includes monitoring. And you can see that in this particular cartoon, that the fundamental part of all this, the foundation for these three pillars, is communicating with patient our goals. So when you think about the goals of managing Crohn's disease, there is a difference, and Millie already showed you a version of this cartoon, this now very well described progression of Crohn's from left to right, where it goes from accumulating inflammation to damage that results in ultimately a patient who may require a surgery. There are two challenges to this cartoon that I want to point out to you. The first one is that we know that many patients have non-progressive Crohn's. We don't talk as much about them because they don't do poorly. And we're learning more about how to understand who they might be. In fact, the guidelines even mention that mild Crohn's may require only a monitoring approach and not an active treatment. But it's the people who have moderate to severe Crohn's that we worry about, and those are the ones in whom we want to change their natural history. We've come to appreciate that symptomatic remission alone is not sufficient, and that endoscopic improvement, or at least other objective measures of the inflammatory problem being turned off, are associated with better outcomes, including reductions in surgery, reductions in need for steroids, and reductions in hospitalization and disability. There's even compelling data that it's more cost effective. So we've clearly moved to all of these outcomes. But the challenge we often face in Crohn's, and I would say that Millie's case outlines it very well, is that we're often catching up. By the time somebody is diagnosed with their Crohn's disease, they may have had it for a very long time. And then the question is, how reversible is what we're faced with? So what we've moved to now in both Crohn's and ulcerative colitis is separating out activity and then severity or prognosis. How sick is the patient currently? Is the amount of inflammation we've identified adequate to explain their current presentation, including their symptoms and other laboratory abnormalities? And what is their prognosis? In other words, what's the likelihood that they might end up needing surgery or end up with a hospitalization or even disability from their disease? So when we look at disease risk in Crohn's disease, we can break it into low risk and moderate to high risk. The patients who are low risk are those who are diagnosed at an older age, whether they are just newly presenting at an older age, or perhaps they've had it for a long time, but it's been very slowly progressive. I sometimes describe patients who have that as having mild Crohn's, but it's accumulated over all the years before it finally was diagnosed. They have limited anatomic involvement, no perianal disease, superficial inflammation or apathy when you do colonoscopies on them. They haven't required surgery, and they don't have stricturing or penetrating complications. Compared with the people that we worry about, those who are diagnosed at a younger age, those with more extensive involvement of the bowel, those who have deeper ulcers when you perform your scope, as well as those who have coexisting perianal or rectal disease. And in fact, there's an interesting and evolving literature on subclinical perianal disease that may be picked up incidentally on MRI. And those patients we worry about just as much, as well as we've seen in many different studies, but not all, that smoking cigarettes is associated with worse outcomes in Crohn's. So you should stratify the individual patient in front of you to their low risk or high risk categories. Now, we've looked at many different ways, and one of the early studies to do this was a claims data analysis that I was part of, where we described that patients who got anti-TNF early after diagnosis without going through other treatments were less likely to have surgery, less likely to lose response, and less likely to need steroids. Now, the interesting thing about this is that our hypothesis in this analysis was actually that by the time people got anti-TNF early, they must be really sick. And we didn't think it was going to make a difference, but it really did. Earlier treatment with anti-TNF in this analysis was associated with favorable outcomes. Fast forward now to the last year at DDW, and now I think it's been submitted for manuscript publication from Mount Sinai, looking at another claims database. Any biologic given earlier in the treatment of Crohn's disease was associated with reduced ER visits and reduced hospitalizations. So we know that when we get people to the therapies that work better, we're going to end up reducing these expensive interventions subsequently. If you go back in our time to the pivotal trials that led to anti-TNF approval, you can appreciate that when you do post hoc analyses and stratify by disease duration, there is a greater likelihood of response and remission when patients have shorter disease duration before they get to these therapies. No surprise. But what I've always liked, and we didn't talk enough about, was another analysis, which was done in the CHARM study looking at maintenance with adalimumab. It's on the next slide. And what that showed was that the shorter the disease duration, the less likely there was for a patient to lose response to adalimumab over time. So to summarize, getting patients on the effective therapies earlier results in a greater likelihood of response and remission and a lower likelihood of loss of response. And now in all of our clinical trials of emerging therapies, we have an analysis we do where we look at patients who are TNF exposed and TNF naive. And repeatedly, we see that when you go to the next therapy, whether it's ustekinumab or vedolizumab, we can see that if you have not already gone through anti-TNF to get to one of these other drugs, you're more likely to respond to those therapies. Now, that may be a clinical trial artifact of who gets into trials, but it may also represent just the importance of getting people on good therapy early enough. So we have a number of prognostic factors that you should be incorporating in your management for Crohn's disease. Every time you see one of these patients, you should not only think about how am I going to make them better today, but how am I going to keep them better later by stratifying them based on prognosis. And in fact, if you look at the AGA care pathway and the ACG guidelines for Crohn's disease, you'll see that both of those emphasize the importance of thinking about prognosis. So if you go to the next slide, you can see both of these have been published in the last few years. And in fact, we now have data backing up these practices, as well as some decision support tools, which we've highlighted for you here in this presentation. Both for ustekinumab and vedolizumab, Parambir Dulai has done some very nice work to give us a tool that might tell you the likelihood of responding to these therapies versus not responding. Now, this isn't perfect. It doesn't tell us exactly that this patient is going to do well, but it definitely gives us some more information to make some of our decisions. And in fact, there's a nice website that you can go to actually put in the scores for your patients and the information and come up with a decision regarding what therapy might be effective for them. This is not quite sensitive enough to distinguish between all our therapies, but it's moving in the right direction. In the absence of therapeutic biomarkers, I like this very much. In the next slide, I want to show you something that was actually highlighted today at noon by Corey Siegel, who did a very nice presentation. It's this newer tool called CDPath, also available online, and it's available free for adult patients. And what this does is it combines a variety of serologic markers as well as the NOD2 genetic marker that some of you may recall, and it gives you the risk of progression of the disease over the next 3 years for an individual patient, low, medium, or high. So if you also are interested in knowing whether your patient has a high risk for progression, which was one of the questions one of the audience members already asked us, you can actually arrange to have CDPath done on the patient, get this graph, and I would argue this is a very helpful tool to communicate with your patient why you might want to be treating a certain way and moving towards that treat to target for them. It doesn't tell you which therapy to use though, but it definitely helps you understand prognosis. So moving on, we also have come to appreciate a few other things about how to optimize our therapies in Crohn's. One of them has to do with combining therapies. And of course, we know from the now landmark SONIC study that combining infliximab with azathioprine is better than either of the monotherapy drugs alone. We've now extrapolated that a bit to our other anti-TNFs, but not to our use with ustekinumab or vedolizumab. We've also learned a bit more about how to use therapeutic drug monitoring. And I want to remind everyone that there are multiple prospective randomized trials supporting the use of concomitant antibiotics with an anti-TNF when you're treating perianal disease. Now, when you try to optimize therapy, one of the questions that may come up is, can we just give more drug? Millie, when she presented CView, mentioned that there wasn't dose escalation of adalimumab or ustekinumab in that head-to-head study. But I want to point out to you that there has been a prospective randomized attempt to look at dose escalation with adalimumab in both Crohn's and UC. Those studies were called SERENE. And in both of those studies, giving twice as much adalimumab and even documenting a higher serum concentration of drug did not improve the likelihood of achieving remission after induction. There was some subtle difference in maintenance phase, but the bottom line here was that there was no benefit to the higher dose loading. So how much can you get out of the drug after you've loaded? And if the patient's not doing well, it's probably time to be thinking about moving on. In contrast, we have seen some benefit to dose escalation with ustekinumab, at least in this real world study from the University of Chicago, my center. What we found was most predictive of people doing well with dose escalation with ustekinumab was if they had already responded or been in remission on the drug and they were out in maintenance phase and had a loss of response. In our study of 500 patients, 20% of them actually were needing dose escalation, and about half responded to decreasing the interval of the drug. And we were pleased with that, and it was predicted by how well they did during loading. So getting back to this treat to target concept that Millie and I have touched on now, the idea for an individual patient is to think about both how sick they are now and what you are going to think about regarding their prognosis. After you choose your initial therapy, you reassess to see if you're achieving a target that you've identified. The standard targets, of course, have been symptom improvement combined with endoscopy, but I'm going to tell you there are some other targets we can consider. In this particular algorithm, you go around the outer circle to try and hit the target with dose adjustments and potentially adding therapies or jumping a class if you're not getting where you need to be. But once you get to your target or once you reach steady state, you enter a disease monitoring cycle, which is an inner circle here. And that's that whole concept of tight control. Remember, chronic diseases tend to drift away from control, and IBD is no exception to that. It's also during the disease monitoring cycle that you might consider de-escalation. So moving on, you can then appreciate the possibility of a variety of different targets. And we only have the studies available currently in Crohn's. It's okay, Jen, you can move on. And the two studies in Crohn's that are available that look at this treat to target have been of great interest. The one on the left is called CALM, in which patients were randomized to a conventional or clinical management strategy based on symptoms or steroid use. And the treat to target strategy was symptoms, steroid use, a calprotectin or CRP. And the patients were driven through the same algorithm of adalimumab dose escalation and then adding azathioprine. It was the first study that we've ever done where the primary endpoint was endoscopic healing. That's interesting to have that in Crohn's. And you can see on the left there that the treat to target strategy had a higher endoscopic healing than the conventional management. You can also appreciate how much more work we have to do. That still more than half the patients didn't get to that endpoint. And then more recently on the right is another treat to target study, very well designed, called Stardust. This one drove the dose escalation with ustekinumab based on endoscopic findings. And you can see the primary results there on the left in that bar chart. You can see that numerically, the treat to target arm driven by endoscopic appearance was better than the standard of care arm, but it was not statistically significant. When they looked at some other statistical analyses, there was a difference between those. But the bottom line here is that using objective markers drive treatment changes and can incrementally, and I would argue significantly, change our management ultimately. So I'll end with 2 points. The number one point is monitoring has to be done by many different approaches, and it depends on what target you use. It depends on how you benchmark it to the patient's endoscopy, and it depends on how often you're going to look based on what therapy they're on or what their risk for relapse may be. Every patient in my practice has a monitoring strategy that is either less or more intensive based on their risk for having problems. And you can think about your patients and what you might want to do. So what I've really come to adopt, and I have a similar approach to my colleague, Séverine Vermeer from Belgium, who published this wonderful article in CGH that I would refer you all to, which is proactive disease monitoring that will drive therapeutic drug monitoring. In other words, interpretation of serum levels of our anti-TNF drugs can be best used when you know whether the disease is active or not. And I think that this is a very nice way to think about it. So in the example in this algorithm, if a calprotectin is higher than 250, they then assess the infliximab trough level to know whether or not the drug should be increased, or maybe that there are anti-drug antibodies present. Now, I don't need to do this with Usta or Vito based on what we've learned about anti-drug antibodies, but I do want to emphasize to you that I think in Crohn's, as in ulcerative colitis, proactive disease monitoring is critically important. So I'll summarize by saying that what I've tried to do here is to remind you that we really have entered an era of disease modification, and we have to include prognosis in the way we manage our patients. We should be treating earlier. We've seen repeatedly that getting patients on effective therapy earlier makes a real difference, short and longer term. And by using treat to target strategies, it implies, and it's very important, that we also use monitoring. Thank you very much for that. So with that, I'm going to take a short break to let Anita take us through learning objective number 3. So Dr. Afzali, the floor is yours.
Thank you so much, David, and thank you all for joining us this evening. So Dr. Long did a nice job of presenting our treatment strategies and basically the medicine cabinet. And then Dr. Rubin shares with us the prognostic factors we should consider, as well as the monitoring strategies. So how do we discuss this with our patients? How do we, in the clinical setting, what is our approach? And also recognizing that there's different factors that will influence our approach. And so now we're going to talk about shared decision-making with the goal, of course, of improving the outcomes for our patients and improving adherence to therapy and having the overall satisfaction. Next slide. So again, the objectives of my portion of the presentation will be to be able to discuss these strategies. How do we engage our patients when we're discussing the shared decision-making model when it comes to Crohn's disease? And how do we improve satisfaction and patient adherence? So let's start with another case presentation. Now we have Patricia. Patricia is a 32-year-old African-American female with a new diagnosis of ileocolonic Crohn's disease. She also has perianal disease with an actively draining fistula. Patricia has had symptoms for nearly 2 years and only recently was diagnosed with Crohn's disease. Her labs, as outlined here, elevated inflammatory markers and normal TPMT, hepatitis surface antigen negative, TB quant negative. She's biologic naive, recently diagnosed. Her family history is remarkable for her mother with a history of breast cancer. Patricia is very apprehensive about the treatment plan and specifically about proceeding to a biologic therapy for her Crohn's. Next slide. So let's take a short pause here. What would your next step be for Patricia? Start prednisone and mesalamine to avoid the malignancy risks in her. Discuss absolute risk versus benefits with shared decision-making. Start vedolizumab as monotherapy to avoid the malignancy concerns and the risks. Or advise her that biologics do not cause cancer and initiate the TNF monotherapy. All right. So that was mostly just to sort of frame this section of the talk. And I think you probably already know the right answer. At least I think we're there. So let's just take a pause here and just recognize what is the patient and the physician or clinician perspective. So this was a nice global survey by David and colleagues, many different countries represented that engaged both the patients as well as the clinicians, the physicians in ulcerative colitis to determine and interpret their level of communication and their preference regarding the communication, the medical communication. So among the patients, 85% were satisfied with the communication that they had with their physician. However, nearly 50% of them still worried that they didn't want to be that difficult patient. They didn't want to get that label of the difficult patient. And about 80% were satisfied with the treatment options. Among the physicians, still the physicians wanted more time with their patients. 75% wish for more time to discuss and or have longer appointment times. So when we look at these different communication perspectives, both from patient and physician, overall, it's clear that our patients may be generally happy with their medical visit and at the time of their visit of having a discussion. However, overall, patients still want to be able to have more information in regards to their diagnosis, their treatment and management plan when it comes to their ulcerative colitis or even Crohn's disease. Next slide. So what do our patients prioritize when they're thinking about the treatment options for them? Well, this was based off of another study. It was a conjoint analysis, including well over 1,000 patients with inflammatory bowel disease, again, from many different countries. And overall, patients wanted the most effective drug, the most effective treatment. That was preferred overall, and they would rather be on the most effective treatment and therapy rather than not. And this was particularly the case in the United States. Of course, our patients also wanted the treatment with the fewest adverse events or side effects. And this relationship was linear. So an increase from 35 to 45% in efficacy was equally as important as 45 to 55. So a linear increase in wanting something that works, something that's safe and effective. Next slide. And so then the next analysis comes with how important for our patients, or do our patients feel it is to be involved in this medical decision-making in regards to managing their Crohn's or their ulcerative colitis. And you can see from here that it's very important. Our patients want to understand their disease. They want to understand their treatment options, the risks, the benefits. They want to be involved in the medical decisions that's involved in their direct care. Very important in 80% of the patients. Less so, much less so, or quite important, but just look at this graph and you will see that our patients are asking to be involved and engaged in their treatment and management strategies. Next slide. So when we talk about decision-making, and you've heard there are different approaches. And for the longest time, the paternalistic approach has been pretty much a one-way street, where we make the decisions based off of our medical expertise, and we expect our patients to comply with what we're stating. Now, on the opposite spectrum is the informed approach. This is, again, still a one-way approach in regards to where we provide the medical information, the treatment options directly to the patient. And then ultimately the patient decides and has the primary decision-making final say in regards to what approach they would want to take in their treatment strategies. Now in the middle, this is what SDM or shared decision-making includes. It's a two-way street. Gone are the days where we take that one-way approach, do what I say, or here's the risk benefits, you decide. Now it's that shared approach. We're taking into consideration, and that discussion becomes with both physician as well as patient. Now all relevant components of the decision-making is discussed, values, preferences are included, and overall now we have a mutual discussion and a conversation with our patients and the physician or provider. Next slide. So this is the approach that we really must follow when we're talking about how do we manage a Crohn's disease patient or an ulcerative colitis patient. This approach, this shared decision-making approach, again, incorporates our patient values, their preferences, and this is what's ultimately going to increase patient adherence and also improve the outcomes of the disease. Next slide. So when we talk about shared decision-making, certainly there are certain scenarios where it's not appropriate. For example, anticoagulation for an emboli. You need to start anticoagulation treatment. That is definitely something you will discuss with the patient, but it needs to be done. But when we're talking about treatment options, Dr. Long and Millie and David both have discussed different treatment options. The medicine cabinet includes different therapies. How do you discuss that? Well, how do we know which one is or is not best for our patients? And as I reminded you earlier, our patients want to be involved in this discussion. So it's beneficial in these situations to be able to lay it all out and have that communication and conversation with our patients. When we're talking about how do we manage our IBD patient, our Crohn's disease patients, we certainly know, as Millie discussed, there's many options for effective therapies in Crohn's disease.
Anita, if I could ask you,
sure.
One of the things that I've come to appreciate is the dynamic nature of the disease, as well as this relationship that we have with people. Can you just comment briefly on how it's different when you're getting to the point of making a decision to induce remission in someone who's quite sick or symptomatic compared to somebody who's now in maintenance phase or post-op, for example?
Yeah, definitely. So when someone is extremely symptomatic, hospitalized, hitting the door near hospitalization or surgery, that certainly requires a more expedited decision making, but it should not take away the shared decision making component. So really, time, sure, it's important, and the emergent or urgent Crohn's disease patient is very different than the maintenance, I'm doing well, but overall, it's the same approach. You need to be able to outline and discuss risk benefits appropriately, make sure our patients understand what that is, and also talk to our patients in regards to, sometimes, I'll be honest, David, sometimes maybe we're just pushing so much one medicine and another medication, and we fail to talk about maybe even surgery. So being able to put and lay out all the options appropriately, discussing the risk benefit, regardless of the time component, is important, whether we're discussing induction of therapy or maintenance.
Yeah, I completely agree. And in fact, treat to target actually allows you to do this too, where you say to the patient, let's reassess after we've done step one, and then we can have another conversation. So absolutely. I appreciate this approach. Okay, yeah. Keep going.
Yeah, so that is the approach that is right here, the 5 A's, A for Anita, or Afzali, or the 5 A's of how to approach the shared.
Our all-star Anita Afzali approach to the A's.
Hey, I like it. We'll nickname it that. Absolutely. So what should our approach be? And so to David's point, when we're talking about whether it's a treat to target approach or whatever, all of this in essence incorporates the 5 A's. So initially we need to assess our patients. We're assessing their disease. We're determining, as David differentiated for us, disease activity from disease severity, identifying those prognostic factors, talking about those factors directly with our patient. That's where advise comes in. We're talking about our recommendations, our management plan based off of the prognostic factors as he outlined. Next, we're agree. So at this point now, this is that shared decision-making component. We're based off of our patient values, their preferences, their concerns, their socioeconomic status. All these different factors start coming into play when we're discussing the agree component. And I'll discuss that a little bit further here, but this is where you absolutely need to understand, most importantly, your patient values, their concerns, and their preferences. Next comes assist. So with assist, this is where you made the recommendation, you made the diagnosis, you've discussed and agreed, but now assist your patient, be that advocate for your patient and being able to help with the coordination of care. Help fight that insurance battle if that's what it takes for the appropriate treatment for each of our patients. Help them with coordinating their colonoscopy and making sure they have a ride or a transportation, for example. These are factors that should and will be and should be continued as part of our role when we're assisting in a disease management such as Crohn's. And then last, it's arrange. Arrange that follow-up visit. Arrange your monitoring strategies. As David said, come back in 3 months, for example, we're going to check another fecal calprotectin. Being able to arrange that component, the future steps and the next steps in our monitoring strategies is also extremely important. So keep in mind this 5 A's model when you're talking and managing and caring for your patients with Crohn's disease. Next slide. So how should we talk about risk? And risk is hard, right? I mean, definitely our patients are concerned. As you recall, Patricia's concerned. She's concerned about her risk for for breast cancer, given her mother's history of cancer. So how do we talk about risk? Risk of medications, for example. How do we communicate that with our patients? Well, it's extremely important to be able to differentiate absolute risk, which is the absolute risk of a disease, of developing that disease over a period of time. And this is expressed in different ways. 1 in 10, 10% risk, 0.1 risk. Then there's the relative risk. The relative risk, it's used to compare the risk in 2 different groups of people, IBD patients on this treatment versus IBD patients not on this treatment, as an example. But you need to know the absolute risk to be able to frame what the relative risk will be and what the eventual risk is. So a 10-fold increased relative risk is how you would describe that. Next slide. And here, this is where it's extremely important for us to be careful with our words. Words matter, and how we describe and display and communicate this with our patients, it's extremely important. So I encourage you to avoid those very vague labels. When you say it's a low risk, what does that mean? Or very common, what does that mean? What's common? So be consistent with how you're communicating and avoid these inconsistent messages or these vague messages. Again, we need to understand and be able to relay the absolute risk, because oftentimes that is a much better representation of what the true risk overall is for a concern, a side effect, an adverse event, and should be used overall or at least compared to that relative risk. Also avoid these decimals. I mean, decimals and at 0.06, that's just really difficult. Too many numbers going on. So avoid decimals, use common denominators, and then being able to, again, have the visual aids. So when you look at the visual aid as an example, so this is one that you can certainly use in clinic. You have 10,000 patients, and again, show visuals. That helps our patients see and interpret a little bit and better understand a little bit what these risks are. And when you're sharing and communicating risks with the patient, it's extremely important to, again, highlight that absolute risk and then demonstrate what the change would be with relative to the risk of a medication, initiating a medication. So again, when you have this visual aid, you're describing directly what the absolute risk is. You're saying, now we're going to add this treatment. Overall, you can see that risk, that relative risk is 2 to 4 out of 10,000, and you have a visual to demonstrate that. Next slide. And so when we talk about the shared decision-making model and how does this impact our patients and with overall satisfaction and adherence and even cost of care, you can see that here, this was a large claims database analysis of about 300 patients with different autoimmune disease conditions or immune-mediated conditions, and it was linked to outcomes. And it was evaluated in regards to shared decision-making versus those who did not have the shared decision-making. So you can see that in the different bar graphs here, overall, the impact of shared decision-making as far as being and feeling extremely satisfied in regards to, again, satisfaction, patient adherence, reduced cost of care was much higher in the shared decision-making group as compared to not. Next slide. So shared decision-making, a patient-centered approach, especially now when we're talking about how we're managing our patients. Millie did a great job of reminding us that now we have these different potential ability to check. I mean, we could do the haplotype checking, we could do these different components, but again, we're talking about personalized approach to caring for each individual patient, and this is where SDM or shared decision-making comes in. This helps our patients improve their level of knowledge and understanding, and as well as satisfaction, better disease outcomes. This improves our relationship with our patients, and it certainly also decreases that decisional conflict. We're wanting them to do one approach, they don't want to do it. Let's try to understand why, what's their reasoning? And we know that, again, this improves adherence and cost of care, and maybe even reduces that malpractice claims and risk there as well. But more importantly, it also reduces some of these health inequities or disparities among some of our underserved populations. Really taking this SDM approach influences that. So when we talk about social determinants of health, or SDH, well, social determinants of health are basically our conditions in the environment that affects a wide range of health, quality of life, outcomes, risks related to many diseases, including inflammatory bowel disease, including the care for our patients with Crohn's disease. So when we talk about the socioeconomic status, now common measures of SES or socioeconomic status includes income, occupation, wealth, education, and all of these are interrelated in one way or another. And so what we have understood is that these different factors or different measures certainly impacts either directly or indirectly outcomes of disease, outcomes of health, outcomes of Crohn's disease. Next slide. And so when we talk about the sociodeterminants of health or the socioeconomic status factors, we have learned that our patients with inflammatory bowel disease have a higher financial toxicity. You know this when you're caring and managing for our patients. The cost of managing this disease is extremely high. Based off of a national health interview survey, 1 in 8 of our patients with inflammatory bowel disease have food insecurity and a lack of social support. So when we talk about and ask our patients to stay on their therapies and be on these different agents, treatment agents, come in, get a car ride, transportation for that colonoscopy or the infusion suite, we have to remember that they don't even have maybe food at home. So we have to understand this impact. Next, the Manitoba Health Administrative Database also demonstrated that our patients with lower socioeconomic status, or LSS, was associated, the outcomes were poorer. These patients who had a lower socioeconomic status had more frequent physician visits, increased hospitalizations, ICU admissions, steroid use, as well as mortality, death. The patients of lower socioeconomic status also had an increased use of narcotics and psychotropic medications, higher cost utilization in regards to caring for and managing the disease, more so for Crohn's than ulcerative colitis. And then lastly, this was able to demonstrate that despite having a universal healthcare system, the Canadian system, this did not ensure that all the patients, all Crohn's patients, all IBD patients, that the outcomes would be equal. So yet again, highlighting disparities in caring for our patients with Crohn's disease and ulcerative colitis. Next slide. And so when we talk about disparities, we also need to recognize that there are the impact of racial and ethnic groups and the disparities among different race and ethnic groups. What we know overall is that there's limited published studies until more recently in regards to the epidemiology as well as the progression of inflammatory bowel disease in the United States, for example. We know for the longest time, it's been predominantly performed among a white population. African Americans from different studies do tend to have more penetrating disease, including perianal disease, compared to whites. There have been differences in treatment approaches also described in the literature, differences in the medical and surgical approach among those patients of different racial or ethnic groups. Now, the question remains, is this because there's a delay in the time of diagnosis? Is this because there's an implicit bias? Is this because there's gaps in our approach of how we approach the care and management of our patients of different racial or ethnic groups? Is there truly a difference in the disease progression or the phenotype? I think this is all a little bit of to be determined, but certainly we've seen some of these differences. Next slide. And so Ed Barnes and the UNC group actually evaluated this a little bit of trying to really understand what kind of factors are really contributing to the differences we're seeing perhaps in outcomes. They're really trying to delineate the differences in disparities among patients with inflammatory bowel disease of different racial or ethnic groups. And they've identified that the disparities are actually multifactorial. When you look here, overall, really only the genetic differences and perhaps phenotypic differences are not modifiable. But when you look at all the rest as outlined, the majority of this, whether it's access to care, the time to diagnosis, the provider decision-making or shared decision-making discussion, even adherence to therapy, the management, insurance, costs, all of these are actually modifiable factors. So when we talk about the differences in the presentation of Crohn's disease, for example, among different racial or ethnic groups, is there really a genetic or phenotypic difference? Or yet again, are we dealing with the issues related to the socioeconomic status, social determinants of health, and health disparities, even when we're discussing how we care for and manage patients with Crohn's disease? Next slide.
Yeah, I just want to add that this article by Barnes and the group at UNC is really a fantastic review. Mm-hmm. And I gave it to everyone on my team, my nurses, my nurse practitioner, my pharmacist, mm-hmm. and I asked everyone to read it. And then we discussed it as a group. So I would encourage all of our colleagues, not just from the US, but around the world, to take a moment and look at this article that's in Press and Gastro. And then think about the populations that you serve and whether or not there may be some ways to identify explicit or implicit biases or deficits in the way you're delivering care. It really had a very strong impact on my team.
That's a great idea. And yes, definitely. It was a great paper and should be read by all. So that summarizes my section as well. Again, really emphasizing the importance of shared decision-making, knowing that that's what's going to result in the best outcomes for our patients, recognizing that how we have these discussions is important. Again, words matter. How do we convey the risk discussion, for example? And then lastly, recognizing the social determinants of health, lower socioeconomic status, and those different measures we discussed, whether it was income, occupation, wealth, education, or even race and ethnicity. We need to recognize that these components impacts the outcomes for our patients with how we manage inflammatory bowel disease and Crohn's disease. So thank you for your attention.
All right, Anita, that's such an important topic. I know that some of it we've heard before, but it always bears repeating in terms of how to communicate with our patients and recognize the different steps we make in terms of getting patients on the same page as us and getting us on the same page as our patients and working through these challenges. And I think there's a lot more work that needs to be done there. So we're going to just spend a minute to wrap up our cases. And then, my goodness, we have a large number of really thoughtful questions from the audience, and we still have 15 minutes to answer those. And I've already peppered Dr. Long with some of them, so she's prepared to help us with that. But let's go back to the very first case. This was Millie's case, Caitlin. Millie, do you want to just remind us in maybe one line what this person had and what we want to do for her?
Sure, yes. New diagnosis of Crohn's disease with a short segment stricture that's very inflamed with pre-stenotic dilatation and quite symptomatic. But remember that she's also interested in pregnancy and she travels with work. So with that background, would you think about surgery, infliximab monotherapy, combination therapy with adalimumab and azathioprine, ustekinumab, vedolizumab, or I am not sure?
So do we get to see pre and post now? There we go. All right. So pre is blue and post is green. So what do you think?
So, I think that with many questions in inflammatory bowel disease, there is no one right answer. But from my perspective, I agree with the majority who said surgical resection, because I'd talked to her about the fact that we could induce a surgical remission on that tight stricture. She's very symptomatic. She has pre-stenotic dilatation. And then, frankly, I would initiate a therapy. She's very young. She's already had stricturing disease. And I would use something in the TNF class and postoperative recurrence. But I think any of these answers, potentially except I'm not sure, would be a good choice for her as long as you monitor, right? Remember, David and I really emphasized the role that monitoring plays. And as we discussed, there was an abstract here at DDW that showed that maybe medical therapy can help some of these, but I would really emphasize a very close follow-up in that scenario and make sure you and she have reached the goals and that she doesn't continue to be symptomatic.
Right. When I give my lectures on prevention of post-op Crohn's, I remind people that the earliest time to start therapy is in somebody who's just had what they used to call a curative resection, where there's a likely risk of recurrence. And I think our therapies truly work better in that scenario. And I'm a big fan of doing that. And I think that is a very nice message. But regardless of what you chose, I do think that making sure they respond and that you get to the goal you're trying to achieve. So the patient understands they're supposed to be living well. And when you work with your excellent colorectal surgery colleagues, this is a way to take control of the disease and move forward in a proactive way. All right, my case was Madeline. You might recall she's 50 years old with ileocolonic Crohn's that has previously been treated with a thiopurine, then adalimumab, then vedolizumab, and then ustekinumab, where she had a response, but really didn't get to remission, is still symptomatic with her standard dosing of ustekinumab. So let's go back to your options here. Infliximab monotherapy, infliximab combo therapy, ustekinumab dose change or escalation, or keep going with the same, just stick with the drug, surgery, something else, or you're still not sure. I've learned from all these years that leaving something else as an option is always a good one when we're dealing with inflammatory bowel disease and our very experienced colleagues. Okay, so it looks like folks were interested in Usta, and there's been a slight tick up on maybe trying to make that drug work a bit more. You heard me say that, at least in our experience, and then at this meeting, it was interesting to me to see some other real-world data with ustekinumab had an identical rate of patients needing dose escalation, and they seem to do okay. So it seems like the majority still want to do that. But not an insignificant number of you thought maybe infliximab, and I'm glad to see you knew that it should be combo therapy based on the SONIC trial, at least initially. So I think that that's right. Surgery in this case is not off the table, but there may still be a way to optimize or consider medical options. Millie and Anita, either of you or both, what do you think in someone who is a primary non-responder to adalimumab? Do you think it's reasonable to still try infliximab in a patient like this?
Yeah, I mean, definitely with the phenotype and what we're dealing with. I mean, certainly as far as aggressive behavior of the disease is worth a trial, so can be considered still. I would do combination therapy in that regards. I don't know if you said that it was adalimumab mono, but combination therapy with infliximab in that situation.
Yeah, I mean, it's an interesting question, and I would do the same. I certainly would think it's still on the table as an option, that we have this feeling that maybe IV and weight-based dosing, as well as the flexibility we have in many cases to do dose adjustments with infliximab, it might still be an option for the patient. So I think that that's
David,
worth considering.
I was going to say,
Millie.
David, for me, I would say definitively if someone has been on adalimumab for UC, and I will still use infliximab, and as Anita mentioned, in combo therapy. But I feel like there's less of a difference between adalimumab and infliximab in Crohn's. And so if someone has been on, an appropriate dose of adalimumab, it's been maximized, and they haven't responded, I think I'm less inclined. I don't know if you all agree, but for me, it's very UC. I would definitively still try it.
Well, I think that you're pointing out something that's really important. Some may remember a study called GAIN, which was patients who were on infliximab and lost response, who then were given adalimumab and demonstrated the benefit. And for the most part, that was when people had developed antibodies against infliximab. So you picked up those patients when you went on to your second anti-TNF. The question regarding whether there's some pharmacokinetic benefit of going to IV infliximab over adalimumab after primary non-response hasn't been definitively answered. But there's a number of analyses. One of my fellows is working on this with a large claims database. Maybe we'll figure it out a bit more, but I think you're right. And we have other options. And the audience seems to like ustekinumab in this patient, at least more time or possibly decreasing the intervals. So interesting. All right, well, let's go to the third case, and then we got to open it up to all these wonderful questions we have. So go ahead, Anita, summarize for us.
So Patricia is our 32-year-old, recently diagnosed with Crohn's disease, perianal fistulizing Crohn's disease, who's concerned about starting a biologic treatment, given her mother with a history of breast cancer. And so your options were as follows, and we'll see what you would want to do now. And I think that we're going to have good results both pre and post.
Okay.
Okay. I think people were trying to just keep it a little exciting for us. All right. So the right answer is shared decision making, right? I mean, talk to your patient. They want to hear more about the treatment, the medication plan, the risks related, discuss those risks, the absolute risks associated with the therapy plan, the treatment plan, the risks related to surgery. Give them all the options and discuss that. I will say, for when we're talking about treatments, the actual treatments, and especially in Patricia's sake, where she is concerned about the risk for malignancy, be able to discuss and have that conversation. TNF inhibitors, as an example, is not associated with an increased risk for solid organ malignancies, and that should be highlighted and conversed with our patients. And also for perianal fistulizing disease, recall that as of right now, to date, it's our anti-TNF agents as a class, as a biologic class, shown both for induction and maintenance trials for fistula response as well as remission. And so keep this in mind in regards to which treatment you'll probably discuss, but it all starts with being able to convey and appropriately discuss with our patients specifically.
All right, terrific. So the final slide is just the specific, measurable, attainable, relevant, and timely goals. We've talked a lot tonight about trying to personalize our approach to patients, recognizing that we don't have therapeutic biomarkers, but we can move through therapies using a treat to target strategy and obviously communicate effectively with our patients to incorporate prognosis in our decision-making and a specific monitoring strategy. And then, of course, recognizing our explicit and implicit biases and the gaps in providing care to those who have specific social determinants of health that are different or socioeconomic status challenges as well. So we have a bunch of questions. I'm going to go through them, and I'm going to try to get us to answer as many as possible in the short amount of time we have. So short question, short answer. Millie, let's follow up with first. COVID vaccines, any data to tell us that we should worry about them in the IBD patients? And how does our audience send patients into your study?
Right. So your patients may have heard about a recent study that looked at infliximab and COVID vaccine, that after one vaccine, there seemed to be an attenuated response. But remember that it's a 2-vaccine series. And here in the US, we're using both. And the second is what really tends to provide the greatest immunogenicity. And we are doing a large study. We'd love to have your patients. It's called Prevent COVID. worldwideweb.ibdpartners.org/prevent COVID. Patients can enroll online. We actually are doing surveys for side effects, outcomes, COVID, but more importantly, we're also sending them to LabCorp, and there are almost 3,000 locations around the US, and they're getting quantitative titers. And I can tell you that we're posting our results online, real time, so patients can look at it. Please send your patients there, even if they just want some information. And I can tell you that thus far, we have seen a great response across many biologic agents and other agents. 93%, up to 95 even, have demonstrated appropriate titers after vaccination. And so, again, I think these data are reassuring. And as we accrue more numbers, we're actually going to be able to look at subgroups and counsel patients over time about the durability of response. So thus far, it looks good, David. And I would not personally alter an agent that is maintaining a remission for a patient to try to achieve some sort of greater response with COVID vaccine. Instead, I would treat their underlying Crohn's or UC and give them the COVID vaccine when they can get it.
Fabulous. So maybe the CME Outfitters will also put the link to Prevent COVID on their website too, as a follow-up from this nice program tonight. Hint, hint, Sherry. Okay, there's a question for me about the CD path. You remember that that's new. That's that new serum test to look at prognosis. CD path, you can look for it online. I have no conflict of interest related to that, other than I think it's a nice thing to have. It's free for your adult patients. It is a blood draw, available in the US only. Sorry for our ex-US folks who are here tonight. All right. The question I'll also answer is, if you want to dose escalate USTA, do you shorten the interval or do you give another IV dose? In general, it's become harder with some payers, but when we do it, we go to every 6 weeks or every 4 weeks. We give it for 3 additional doses and we reassess our target. But now I'm going to throw it back to Millie to ask you, do you think CView will modify your approach to any patients with Crohn's, and if so, how?
You know, I think that CView data were really reassuring to me, that we have 2 great agents, ustekinumab and adalimumab, that have great responses. You know, I think that I think the safety data from ustekinumab are outstanding, and that if I would feel very comfortable initiating a patient on either agent, you know, based on those efficacy data. It doesn't really give us one has a leg up over the other, but I think that in the past, I really felt that TNF was king from an efficacy standpoint. So I'm glad to see that ustekinumab has great efficacy as well.
Anita, there's a question here about, if a patient has joint pain related to their Crohn's, would it influence your choice of therapies based on what we talked about tonight? Can you comment on that?
Sure. I think it's important to be able to differentiate if the joint pain is related or is related to the underlying bowel disease. We know that there are certain arthropathies that parallels bowel disease activity. Control the inflammation of the gut, the joints improve. So first you need to understand what's happening in the gut to understand what's also happening in the joints. And then at that point, it would influence. If there's no active inflammation of the gut, the joint pain, I would want my rheumatologist to assess first. But if there is active inflammation of the gut, whichever treatment you could initiate as soon will hopefully improve both gut and joints.
Thank you. Question about increased side effects with decreased intervals of USTA. The answer is no. There's not a dose toxicity. So we've seen that across the pivotal trials and in our experience as well. Safe therapy, even when given more often. Millie, somebody wanted to know, how does the patient wanting pregnancy influence your treatments? We didn't go back to that specific question in detail. So would there be any concerns regarding any of the therapies we talked about?
Not any of the biologic therapies we talked about today, but I do have concerns surrounding tofacitinib for ulcerative colitis. And so when I'm having conversations with young women, starting them on therapies for UC, that's something I will discuss. We really just don't have enough data yet, and there's some signals in animal studies of harm. And so I just think we need a better data before going there.
So with ustekinumab in particular, I'm familiar with a series of 438 women, maybe it was 478, who had received the drug and were pregnant for any indication, and those outcomes look similar. So good to know that as well.
And piano did include women on ustekinumab as well.
Yeah, so we're comfortable with that, like we are with our other monoclonal antibodies. Anita, how do you improve adherence to medications given some of the social determinants of health? Do you have different approaches for different individuals? Who's higher risk, and what's the communication strategy?
So being able to understand what components that may impact their adherence. Is it being able to not have a ride to come to the infusion center? Absolutely. I would not start them on an infusion needed treatment. So being able to understand what factors may influence their adherence. And it comes down to being able to talk and ask directly. I ask them, do you have a ride or are you able to drive yourself? And I converse, just talk to your patients. I think that's what it comes down to.
Well, I'm sorry that that's all the time we have. I know there are some more questions that we didn't quite get to, but I know my faculty and I know myself, and we would love to hear from you if you want to tweet at us or send us an email. But to remind you to receive CME and CE credit for today's program, we need you to complete the post test that's on your screen and then click on request credit to complete the evaluation. We really need the evaluation so we can continue to improve these programs. And then you can print or download your certificate. If you have colleagues who missed today, or you want to hear it again because you just loved hearing Millie and Anita, this webcast will be available on the Gastroenterology Hub, in addition to other resources like the link to some of the things we talked about tonight and the Prevent COVID study. I would like to thank Doctors Anita Afzali and Millie Long for joining me today. And I want to thank all of you for joining us tonight. Impressive. You were at a very busy virtual DDW and you stuck it out until Sunday night. And I would lastly like to thank CME Outfitters for their assistance with what was a flawless program. And we appreciate all the detail that goes into that. Wishing you all very well. And I hope we will see each other in person next year.
Oh, we hope.
Yes. Thank you all.